All right. Hello, everyone. Welcome back. I hope you've been having as good a day as I have. This has been a terrific series of sessions, and this one will be no exception. This is our third panel entitled the. Do you want me to start over or? Okay. The third panel is entitled The Importance and Value of the Integration of Health and Immigration Data. So it's my pleasure to introduce the moderator of this panel, Sujitha Ratnasingham. Sujitha is the Director of Strategic Partnerships and the Operational Lead of the Indigenous Portfolio at ICS. In her role, Sujitha focuses on building partnerships with key stakeholders, including Indigenous organizations. And Sujitha also co-chairs the ICS EDI committee and is a member of the ICS Race and Ethnicity Data Working Group. Over to you, Sujitha.
Thanks so much, Michael. Sean, if you could share the slides. Perfect. Thanks so much again, Michael. So today we'll be talking about the importance and value of the integration of health and immigration data. We'll be focusing on the value of research related to newcomer health in Ontario, which has been made possible by the partnership between IRCC, which is Immigration, Refugees, Citizenship Canada, and ICS. This partnership and subsequent integration of health and immigration data has led to studies of significant value to government and policymakers. I would like to start off by introducing our panel. First, we'll have Seema Gandhi, who is a research program manager for the Mental Health and Addictions program at ICS. Prior to this role, she was a senior epidemiologist working on a diverse portfolio of projects, including mental health and addictions and the long-term health and social outcomes of immigrants and refugees. Next, we have Dr. Sujitha Wanagaratne, who is a social epidemiologist and senior research associate at the Edwin S. H. Leong Center for Healthy Children at the Sick Kids Research Institute. She's also a fellow at ICES. Sujitha's research examines immigration as a structural and social determinant of health and has experience working with community-based participatory research methods. Finally, we have Sarah Trottier, who is a Director of Data, Growth, Culture, and Information Sharing at IRCC. Sarah is a federal government executive who has dedicated her career to delivering on the mandate of IRCC through various positions she's occupied. Her current focus, under the direction of the Chief Data Officer, is growing the data while delivering a concrete path forward to augment data literacy amongst the workforce. Next slide, please. So we'll start off with a very quick overview of the IRCC-ICS partnership, followed by presentations by our two researchers. First, Seema will speak to COVID-19 and immigrants, refugees, and other newcomers in Ontario, followed by a discussion on COVID-19 vaccine equity by Sujitha. And then finally, Sarah will speak to the value of the IRCC ICS data linkage for public policy relevant research and analysis. And finally, there'll be an opportunity for the audience to ask questions of our panel members. Next slide, please. Starting off with a quick overview of the history of the ICS-IRCC partnership. This began with a single project in 2002, roughly a decade after ICS was formed. Since then, we have expanded the partnership to include collaborative workshops to better understand the integrated information and share findings. Most recently, the data received by ICS has expanded to include the temporary residence file. Next slide, please. Initially, the data shared with ICS included information only on permanent residents who had landed in Ontario. This created a gap as we are aware that many immigrants land in other provinces and then subsequently move to other provinces or territories. In addition, IRCC has now shared information on temporary residents who may face unique health challenges. These data are currently being integrated at ICS. Next slide, please. This figure shows that nearly 4 million immigrants in Ontario have been able to be linked to the IRCC data. This includes roughly 580,000 refugees. Studies using these data have been conducted in various areas, including access to care, mental health and addictions, and focused reports on newcomer health. Today, we will hear from researchers about 2 studies focused on immigrant health related to COVID-19. Next slide, please. So to start off with, I'll turn it over to Seema.
Okay. So the title of this presentation is COVID-19 in Immigrants, Refugees, and Other Newcomers in Ontario, Characteristics of Those Tested and Confirmed Positive as of June 13, 2020. Next slide. So to provide some background and context about immigration in Canada, Canada received an average of 275,000 immigrants as permanent residents annually over the last 10 years, among whom approximately 50% were received in Ontario. They do represent a group that are important to our economy, filling many skilled, semi-skilled, and unskilled labor market needs. And in terms of what we know with regards to COVID-19 in Canada and globally, COVID-19 infections have disproportionately affected immigrants in certain racialized communities, highlighting societal and structural inequalities, placing immigrants and racialized populations at greater risk of COVID-19 infection and severe related outcomes. So in 2020, a few months since the start of the pandemic, the City of Toronto had released a report highlighting the disproportionate number of COVID-19 positive residents in Toronto who self-identified as Black, South Asian, Latin, Southeast Asian, and others. And so this served as the basis of our report, which was initiated as an applied health research question project at ICES. Next slide. And therefore, the objectives of our work or our report were to examine the patterns of test results among immigrants and refugees during the initial phase of COVID-19 testing in Ontario. This period started on January 15th, 2020. And of course, this work would not have been feasible without our partnership with IRCC, which permits the linkage of IRCC permanent resident files with ICS administrative data holdings, which also includes COVID-19 test data. A unique element of this project was also the formal engagement of the ICS Public Advisory Council. And this group represents a diverse group of immigrants and individuals from different ethnic backgrounds who played an instrumental role in decisions related to data analysis, interpretation, contextualization, and presentation of results. Next slide. And so our study included all community dwelling residents in Ontario eligible for the Ontario Health Insurance Plan, excluding long-term care residents. Immigrants and refugees represented in this analysis include those who obtained permanent residency status between January 1st, 1985 and May 31st, 2017, just based on the availability of IRCC data at the time of analysis. Individuals born or living in Ontario without a record in the IRCC database were categorized as Canadian-born or long-term residents, and so these may also include those who may have landed in a different province. And in the absence of immigration data, those who became newly eligible for OHIP coverage after June 2017 were grouped as newcomers. Next slide. Yeah, perfect. Okay, and so this is an infographic pulled from our report, which provides a visual of how we grouped permanent residents for the purpose of our analysis, which largely reflects their status at landing. So I know it's a bit of a busy slide, so I just want to highlight that we had our newcomers, which, like I mentioned, became eligible for provincial health insurance after May 31st, 2017, and therefore may include immigrants and refugees for whom an IRCC record was unavailable at the time of analysis, may include temporary residents or those who migrated from another province. Then we have our immigrants that represent about 3.2 million individuals in Ontario, and therefore the categories included sponsored family immigrants, economic class immigrants, which we further subdivided as caregivers and other. Caregivers because they account for a large portion of healthcare workers as well as live-in caregivers. And then we have resettled refugees who were selected through the UN Refugees Resettlement Program, who are also subdivided into their respective groups, which include privately sponsored refugees, blended visa office referred refugees, and government assisted refugees. We also have protected persons in Canada. And so these represent individuals who landed as asylum seekers or refugee claimants, as well as other refugees who may have been living abroad at the time of application. And lastly, we have sponsored and unsponsored individuals, which we refer to as those who landed here due to humanitarian or compassionate causes, who may not otherwise be captured in other categories. Next slide. Okay. And so this is a list of data sources that were used for the report, which were for the purposes of a range of different variables, including immigration characteristics, sociodemographic characteristics, case information and healthcare worker status, testing data, and clinical characteristics. Next slide. And so our analytical approach was as follows. So to capture the heterogeneity among this group, we examined intersecting factors which may have contributed to COVID-19 infection among immigrants and refugees in particular. So this would include recency of immigration, region of birth, language ability, and level of education. Also, COVID-19 testing data was available through multiple sources. COVID-19 cases were obtained through the Integrated Public Health Information System, which also was used to identify those who were flagged as healthcare workers, and then linked to multiple health and demographic administrative data sets to examine baseline and sociodemographic characteristics of Ontario residents by immigration status as of March 31st, which was 2020, which was used as our index date. Next slide. So I'll just present some of the highlights from our report. And so this graph shows the proportion of residents tested for COVID-19, as well as percent positivity for COVID-19 among those tested, and per capita positivity in Ontario by immigrant category. So based on about approximately 624,000 individuals tested in Ontario, among whom 25,000 tested positive at the time of analysis, we found that although immigrants and refugees and newcomers make up just 25% of the Ontario population, they accounted for about 45% of all COVID-19 cases. However, they also had the lowest rates of testing compared to Canadian-born and long-term residents, with exception for economic caregivers, which reflect a high employment in the healthcare sector. This graph shows the results for percent positivity among those tested and per capita, and therefore percent positivity in those tested and per capita were higher among all immigrant categories and among other newcomers that compared to Canadian-born and long-term residents, except for immigrants classified as economic caregiver, who had the highest per capita positivity compared to all other groups. Next slide. And so this figure shows the rates of percent positivity among those tested by world region of birth among immigrants and refugees. The dotted line here shows the overall average for all immigrants and refugees, with the light blue line showing the results for Canadian-born and long-term residents. And so here we see that the highest rates of positivity by world region were among immigrants and refugees, were the majority who represent racialized groups in Canada, so notably Central, Western, and East Africa, and South America, the Caribbean, Southeast Asia, and South Asia, as you can see on the figure to the left of the figure. Next slide. And so this graph also shows similar results, however, this is per capita positivity among immigrants and refugees. And so we're seeing the similar results for some of our world region of birth. And so next slide. And so this figure is an overview of healthcare workers in Ontario who were confirmed positive for COVID-19 by immigration status as of June 13th, 2020. And so using the healthcare worker flag in the IFAS data, we were able to determine the proportion of individuals employed in the healthcare setting. So among all adult females who had tested positive, 36% were employed as healthcare workers, among whom immigrants and refugees made up about 45% of these healthcare workers. And then we can see that the top country of birth among these individuals were largely the Philippines, Jamaica, India, Nigeria, and Guyana. Next slide. Okay, and here we have the proportion of Ontario residents who tested for COVID-19 and percent positivity in those tested by immigration status and neighborhood income as of June 13, 2020. And so here we can see that some neighborhood demographic characteristics had a differential effects on rates of positivities among immigrants and refugees compared to Canadian-born and long-term residents. So while testing rates were higher among those living in low-income neighborhoods for Ontarians in general, positivity was strongly correlated with living in lower-income neighborhoods for immigrants, refugees, and newcomers, but not necessarily for Canadian-born and long-term residents. Next slide. And here we are seeing similar results, but here we're looking at higher household densities, right? So this is based on persons per dwelling. And so what we're seeing here is that living in neighborhoods with higher household densities or persons per dwelling was associated with higher positivities among Ontarians in general, but far more for immigrants, refugees, and other newcomers, where living in multi-generational households may be more common. Next slide. And here we're looking at results at the public health unit level. So here what we see is that public health units with large immigrant and racialized populations, notably Peel, Toronto, Durham Region, Waterloo, and Windsor, as well as York, experienced the highest percent positivity among immigrants and refugees tested for COVID-19, as represented here with the darker colors on the slide. Okay. So next slide here. And so our findings point to the emerging evidence around important inequities in testing and positivity for COVID-19 infection in Ontario. Systemic inequities have resulted in income disparities and related precarious employment and housing for many immigrants and refugees. Highlight the need for public health initiatives to mitigate the barriers around a disproportionate burden of COVID-19 infection. And such initiatives may include more accessible testing, workplace safety, and working with organizations that represent high-risk communities. Okay, next slide. So now I'm going to present some of the knowledge translation and collaboration activities that took place following these analyses with some of our local public health units. Okay, and so in November 2020, ICS collaborated with select public health units that had the largest representation of refugees to provide regional level data on COVID-19 testing and positivity. And so some of these public health units included Ottawa, Peel, York, Hamilton, and Toronto. And then following the availability of data on vaccine uptake, regional level results were provided to public health units with a focus on examining socio-demographic and immigrant characteristics of individuals who are fully or partially vaccinated or unvaccinated. And so if we refer to the next slide, this is a figure that shows the proportion of unvaccinated individuals as of June and August 2021. So 2 phases of analyses, and this is specific to the Toronto Public Health Unit. And so here we can see that in the Toronto region, vaccine coverage was lowest among immigrants and refugees from select world regions, notably Africa, Central Africa, Eastern Europe, and the Caribbean during both time periods. And then when we looked at this by specific countries of origin, we were able to drill down a little bit to vaccine coverage, which was lowest among immigrants and refugees from some countries in the Eastern European area, so like Russia, Poland, and Ukraine, as well as some from the Caribbean. Next slide. And so in particular, there was some ongoing collaboration between ICS, the City of Toronto, and Toronto Public Health, who engaged in a series of knowledge dissemination activities during the initial vaccine rollout. These data were instrumental for stakeholders at Toronto Public Health as they were directly involved in targeting underrepresented groups. And so therefore, these results were leveraged with the following initiatives and organizations, including the Interlib Immigration Partnerships, which is funded by IRCC and is a collaborative initiative to enhance the delivery of services among immigrants, refugees, and newcomers. as well as the Newcomer Leadership Table and the Black Resilience Community Center. And so all of these initiatives and organizations are directly involved in working with racialized communities, immigrants, refugees, and newcomers with respect to improving service delivery. Next slide. Another one was the Eastern European Vaccine Engagement Teams that held, and this is the example we wanted to share, as the Eastern European Vaccine Engagement Team led focus groups with community agencies who directly work with Eastern European communities to better understand what some of the barriers around vaccine uptake and how change could be implemented based on feedback received directly from members of the community. And so several themes that had arisen from the focus group did arise. However, we did want to acknowledge that the reasons for why people are unvaccinated or under vaccinated are very complex. And so some of the themes that we're going to share came from community members. However, there may be other reasons that we might not be able to capture. And so just around vaccine hesitancy and barriers to vaccination, this may be based on some of the themes that arise were historical mistrust of government or just miseducation of vaccine composition, health concerns and religious beliefs. And then some of the other things that were discussed during these focus groups were engagement and outreach approaches. So, leveraging existing trust from community members and cultural representation and language-specific communication, having political representation, targeting youth posters through culturally sensitive means, and then improving communication channels and networks. So using local media, physicians who speak Eastern European languages, involving Polish Canadian Congress, leveraging support from local communities such as religious influencers and online groups. And so these were some of the themes that had arisen through the focus groups and that were basically informed to use some of the vaccine strategies and policies for some of these local high-risk communities. And I will now pass it on to Sujitha. Thank you.
Thank you so much, Seema. As Sujitha mentioned, my name is Sujitha Wanagratney, and I'm a social epidemiologist and senior research fellow at SickKids. And I'm going to just expand a bit on the work that Seema described in terms of vaccine uptake and share with you two of the studies that we have done, which linked IRCC data and the Ontario COVID vaccine data. And we did this to examine vaccine coverage among immigrants and refugees in Ontario. And really what both of these papers do is really trying to determine whether vaccine uptake and coverage was equitable for immigrants and refugees. And what I mean to say when I refer to vaccine equity is that I mean that everyone should really have fair and just access to vaccines. And given the theme of the research forum today being health equity, I'm sure we're all aware what health inequities are, but I just want to put a little bit of a reminder here just to orient ourselves to this work. So inequities disproportionately impact those that are most disadvantaged by social and structural forces. And importantly, they are avoidable and can be mitigated by targeted social policies. Next slide, please. So in terms of thinking about vaccine equity in relation to immigrants and refugees, we know that from what Seema just presented to us in terms of testing and positivity, we do know that immigrants and refugees in Ontario were disproportionately impacted by infections, COVID infections. We do also understand that this was really the result of a really complex web of social and structural factors, some of which include that, immigrants were more likely to be working frontline jobs, they were more likely to be, or less likely to be working from home, less access to paid sick leaves, and many other factors. And therefore, given this, we know that they would also benefit greatly from vaccinations in terms of avoiding hospitalizations and mortality. From the global literature and internationally, we know that immigrants also experience unique barriers to vaccinations, and some examples of this that, emerged during the pandemic and are also in the literature is that immigrants and refugees can have increased susceptibility to vaccine information, particularly if that information is not available in the language that they are best able to communicate with in terms of health information. So they may seek this information through unofficial channels, through family and friends, and this information could be misleading or inaccurate. So that's kind of just one of the barriers that we know exists for immigrants and refugees. So in terms of, sorry, I'm just going to say one more point on that last slide. So just in terms of thinking about, again, globally, that immigrants and refugees we know from the literature that they globally have experienced disproportionate burden from infections and severe outcomes. We also know that they have barriers to vaccine uptake. There are surprisingly very few studies that actually examine vaccine uptake, so that we're filling a gap with these two studies here. So next slide, please. So this first study focuses only on adults, and we do a subsequent study, which I'll describe in children and in adolescents. And for this first study, we looked at primary series coverage, so the first 2 doses, as well as third dose coverage, so that first booster. And there's the team that we work with on this study, led by Astrid Gutman. So next slide, please. So I thought I'd just quickly go a little bit of a timeline just to remind ourselves. Not sure if we're not that far removed, but just to orient ourselves to the timeline again in terms of vaccine rollout and the pandemic itself. So I'll just ask you to focus on the bottom. So we know first doses were first available in December 2020. Second doses available in May of 2021. Third doses became available in September 2021 also. Shortly after that, vaccine passports were implemented in Ontario in terms of looking at whether people had 2 doses, and this was the program ended in March 2022, and that was also around the same time that mask mandate started to be removed as well. In terms of thinking about vaccine equity in Ontario, it's really been a concern in the province since the beginning of, when the first doses are rolled out. So an example of this was that in April and May of 2021, there were some neighborhoods that we knew experienced high rates of infections as well as severe outcomes. And these were allocated additional vaccines in order to try to avoid those infections and severe outcomes. So that was one way that equity was specifically targeted. We also know that vaccine data was used to inform the location of mass vaccination clinics and pop-up clinics. And we also know there's really, innumerable examples of community-led vaccine efforts that were aimed to reduce infections and really try to promote high primary series coverage. And comparatively, just given this timeline, that there were just fewer policies and programs that really advocated for first booster coverage. So next slide, please. So in terms of the objectives of this first study, we compared primary series for this, again, those first 2 doses and first booster coverage, the 3 doses. We compared those 2 between immigrants and other Ontarians. And this was across many sociodemographic, primary care and immigration characteristics. We also separately examined the association between vaccination status among immigrants as well as all Ontarians. So that was just in terms of the modeling. So next slide, please. So the key databases, we've already talked about the IRCC database. During the pandemic, we did receive an updated database. And so this data included additional data to what Seema had referred to in her presentation. So we did have arrivals up to September 2020. And the other key database we used was the COVAX Ontario database to link those two and get that information. So next slide, please. So again, on the bottom is that timeline that I referred to already. So this just kind of anchors some of the design choices, methodological choices we made for this study. So in terms of design, it was a population-based cohort study. We include all community dwelling adults. So we excluded all people that lived in long-term care homes. And everyone would have been OHIP eligible and older than 18 as of January 2021. So the first outcome that we looked at was primary series coverage, and that was measured on September 13th, 2021. And so essentially we included vaccine data for, that first bracket there. So about a year's worth of coverage for primary series. And then for the second dose, for the second outcome, we looked at first booster coverage. So up to that third dose, which was measured on March 13th, 2022. Next slide, please. So the main exposures that we were interested in, again, they focused on what was in the immigration data, what we had. So the first variable was immigration status, and this was operationalized using many of the categories that Seema described earlier. And the comparison group we used was other Ontario residents that are essentially those not in the IRCC database. And these immigration categories are really quite important because they represent really different immigration pathways to Canada. They are both shaped by the social determinants of health, things like education, as well as official language ability, and then they can further influence access to the social and structural determinants of health after arrival in Canada. The second exposure that we looked at was region of birth, and we conceptualized this as a proxy for barriers experienced due to social exclusion. And we also considered this to be a very imperfect proxy for vaccination barriers that could be related to different cultures, different religions, different languages, etc. In terms of covariates, we adjusted for some of these in our models, or we looked at them descriptively. So these were age, sex, primary care, model affiliation, neighborhood income. We also looked at neighborhood COVID risk deciles. So essentially, neighborhoods throughout the province were ranked in terms of their COVID risk, and we were able to kind of look at how some of the targeted efforts were made according to those neighborhoods. We again looked at immigration category and duration of residence as well. Next slide, please. So here are some descriptive results. Just in terms of the population, we had about 12 million adults and about all adults together, and around 2.5 million immigrants and refugees. In terms of how immigrants compared to other Ontarians, immigrants were less likely to be 65 years of age, they're more likely to be less than 65 years of age. They were more likely to live in neighborhoods in the lowest neighborhood income quintile, and they were very much more likely to be residing in neighborhoods in those three highest risk deciles that I spoke about previously. So just in terms of vaccine coverage there on the right side of the graph, you can see the pink bars depict 2 doses, and the turquoise bars are 3 doses. So you can see that the difference between immigrants and refugees and other Ontario residents for 2 doses was very small, so less than 5% difference in coverage. But then it was much wider for 3-dose coverage, so more than 12% difference there. When we looked at differences across many characteristics, the trend essentially was that there are very few differences between immigrants and refugees in terms of 2 doses, but there were many more differences, and they were quite large for 3 doses. So I can talk about those a bit more on the next slide. So here is what this looks like for those neighborhood risk deciles I spoke about. That's kind of the graph in the middle, and then neighborhood income on the right side of the screen. So what you're looking at here is the difference. The bars depict the difference between immigrants and other Ontario residents. And so if that bar is on the negative side, immigrants had lower coverage than other Ontario residents. So you'll see for the neighborhood risk deciles that for 2-dose coverage, that in the highest risk deciles, that the difference between immigrants and refugees was quite small. It was less than 5%. And this was really prominent in the higher risk deciles. This really demonstrated that the targeting of those neighborhoods to reduce inequities was quite effective because that difference is so small. But again, comparing the 2 doses to the 3 doses, the coverage we see there's much greater differences between immigrants and refugees in terms of the 3-dose coverage. And also just shifting over to the neighborhood income graph, you can see that, again, the difference between immigrants and refugees is quite small for 2-dose coverage for that lowest income quintile, which was really quite striking. So there's, suggests, effective targeting of inequities as well in terms of 2 doses. And again, you see the wider inequities in 3-dose coverage in that graph as well. So next slide. So here we have some modeling results looking at region of birth, immigration category, duration of residence, as well as primary care enrollment. And just in terms of region of birth, this resonates also with what Seema presented earlier. Some of the regions that demonstrated lower coverage. So sorry, just to say that the gray squares indicate primary series coverage, and the black squares indicate the first booster coverage. Folks from Central Africa, from Eastern Europe, and the Caribbean had much lower coverage compared to the average, which is Southeast Asians. But then, you look at all of those groups and you see that they all had lower coverage than Southeast Asians in terms of both doses. And just to note also that Southeast Asians, the coverage was quite similar compared to other Ontario residents. So this graph looks quite similar when we're looking at the whole population as well. There also are a few examples of where the regions were quite similar in terms of coverage. So, the circles on the region of birth graph just kind of demonstrate where coverage was quite similar for the two doses. For immigration category, what was most striking was for resettled refugees and protected persons, which were former asylum seekers, compared to other economic class immigrants. We found very less variation by duration of residence than we expected, so not too many differences there. But we also found, in terms of primary care enrollment, quite strikingly lower coverage for both second and third doses when people did not have any primary care visits in the previous 2 years, and this was compared to those that were enrolled in a primary care model. So next slide, please. So briefly, some thoughts on summarizing this, as well as some concluding thoughts, was that I think our results really demonstrate that the policies and programs that included more equitable distribution, lots of public health outreach, and, as I said, numerous community-led outreach efforts were very successful in achieving equity in primary series coverage. And I just, on the right side of the slide here, I just have a few of the examples of news coverage of community-led efforts that are really, really important in that effort. And I just want to pull out one quote from Dr. Lawrence Lowe, who was the former medical officer of health for Peel Region. And really, in this quote, he just, is grateful to many community organizations, the Canadian Muslim COVID-19 Task Force, the South Asian COVID-19 Task Force, Latin American Task Force, Black Health Task Force. And she said they were tireless in their efforts. They worked, going door to door, getting bookings, people getting transportation networks set up. And he really indicates that the secret to their success was all of these great efforts by communities. So I just wanted to point that out to kind of support that as well. The other thing we noticed was that there was really wide inequities in third dose coverage. So there's really a need to reinvigorate those public health policies that were effective in getting primary series coverage and beyond, again, including community-led efforts. Our region of birth results suggest that the barriers and facilitators are really quite heterogeneous and a very diverse immigrant population in Ontario. And really, I think this supports the need to cultivate community participatory strategies. So next slide. So I'll just quickly move on to the results for children and youth. And this was our team again, led by Astrid Gutman. Next slide, please. So the objectives for the study were to understand the characteristics of immigrants and other Ontario residents that were associated with COVID-19 vaccination. And really the purpose of this was to try to inform the continued vaccination strategy for children and youth in the province. The design was a population-based cohort study. Next slide, please. So in terms of some methods here, we included all children under the age of 18 who were OHIP eligible as of January 1st, 2021. The adolescent vaccination campaign began in May of 23rd, 2021, and the children's vaccination campaign started on November 25th, 2022. And we essentially measured up to 2-dose vaccine uptake among adolescents, so those that were 11 to 17 years old. And we measured at least one dose uptake among children. So those were 4 to 10 years old. And we did that as of April 24th, 2022. So we had about, 6-month observation window for children and about a year for adolescents. Next slide, please. So in terms of our exposures of interest, again, we were interested in both the immigration category, measured similarly as I already spoke about, as well as region of birth. One thing that we were able to do in this study was also look at generational status. And really what this means is that we were able to identify a group of children and youth in Ontario who were born in Ontario, but their parents were actually immigrants. And so we referred to those folks as second generation. And really the rationale for looking at this group is that we thought that, this group of children have parents who had more experience with the healthcare system because they had children born in the province. So they were probably able to navigate their children more easily to vaccination than first generation children whose parents were also immigrants. That was kind of our hypothesis around looking at second generation kids. Next slide, please. So some results here, we included about 2.2 million children and adolescents. There are about equal proportions of both age groups of children in that population. Children, among the children's group, there were a smaller proportion of first gen children, but a lower proportion of first gen children, a higher proportion of second gen children compared to adolescents. Looking at coverage on the bottom, the graphs there on the left side are children, right side are adolescents. And so for at least one dose coverage among children, looking at first generation children there in the pink bars and second generation children in the green bars, you can see that, second generation resettled refugees and protected persons had very slightly higher coverage compared to their first generation counterparts, but still quite similar. I think what was striking in this graph was that other immigrants who were first generation children had the highest coverage compared to all of the groups. For adolescent coverage, we see that they're really quite similar across the two groups. Not a whole lot of difference in terms of first generation and second generation. Really quite similar across. Next slide, please. So these are just modeling results, demonstrating similar statements to what I had said in terms of the previous slide. So all of these were compared to all Ontario residents. There's first generation folks kind of on the top of those graphs, second generation children on the lower part. And here we demonstrate the odds ratios, and we find that first generation non-refugee immigrant children and adolescents had higher coverage. So they're on the right side of the forest plot there. And we also see that second generation children and adolescents whose parents were resettled refugees, as well as first generation children and adolescents who immigrated as resettled refugees had lower coverage. Next slide, please. So there were meant to be animations on this slide, so I'll just describe to you what I was trying to get at. So this is children and adolescents in two separate graphs. These are all the regions of birth that we looked at, similarly to what we looked at in adults. In each, the comparison group for each of these groups, so black dots are first generation, the red squares, which are quite small, are second generation. Each group was compared to its group average. And we see, if we just kind of look at the regions separately, we see that similar patterns to what we saw in adults. Regions that had lower coverage were folks from Central Africa, the Caribbean, again, Eastern Europe also pops out. In terms of comparing across generations, we can see that there are some regions that have similar coverage. So there's no difference between first and second generation coverage, whereas there are some regions that have very, very differences between second generation and first generation coverage, and some of those those that there are some groups where second generation actually has better coverage. So folks from East Asia, for example, whereas there are some countries, some regions, where second generation has lower coverage. So an example of that is Southeast Asians among in the youth group. So lots of variation there, looking at region of birth and stratified by generational status. So next slide, please. So the summary of our main findings were essentially that there was lower coverage in children compared to adolescents. The inequities were much more pronounced in children than in adolescents. Coverage was greater for first generation other immigrants, so those that were non-refugees. Coverage was lower for first and second generation resettled refugees. Both of those groups kind of stood out. Again, there's very high variation by region of birth. And as I said, within regions, some regions demonstrated similar coverage by generational status and other demonstrated differences, and it wasn't consistently better for second generation children. So next slide, just quickly in conclusion, we think there are definitely, this stands for both adults and children. We need additional studies to really understand what the barriers are to uptake of these vaccines. And I think, having disaggregated data really helps us develop, precision public health strategies and approaches. And these can inform, including, community-led strategies, which is what, Seema demonstrated in her part of the talk as well. So, we need these for the continued strategy for COVID-19 vaccinations, as well as future vaccine campaigns for other vaccines as well. And so with that, I will end my part of the talk. Thank you.
Bonjour, mon nom c'est Sarah Trottier. First, I just want to acknowledge that I'm on the unceded, unsurrendered territory of the Anishinaabe Algonquin Nation, whose presence here reaches back to time immemorial. Si vous avez des questions en français ou en anglais, n'hésitez pas à me les poser. Je suis entièrement bilingue. I am conscious of time, so I did have a whole presentation, but I think I'll skip to what's most important for some of you. So if you go on the next slide, we have the context of who we are. You can Google that. I'm sure it's not a mystery for some of you. Where the main focus is immigration, refugee, and citizenship. We're mostly a very operational department where we process a lot of files, which means we hold a lot of data. If you go to our next slide, this is our context in which we operate from a data perspective. While we want to facilitate data linking and data sharing, we also are bound by some of our privacy regulation and the Act. So we do the art of possible, and this linking is one of them. It's the art of possible. On the following slide, it explains a bit what my team's job is from a day-to-day perspective. So they work in close collaboration with many research centers and other academics to enable the research through a data lens. Without digging through into the steps, if you have questions at the end, you can always email us and we can walk you through the world of possibilities. But I thought I would spend more time on what's relevant. How is this relevant for us? While our journey, while the slide you see here is quite slim, because really everything that Sujitha and all the other presenters put forward is really specific to health, and we don't have a health mandate per se. We do control some health screening when we onboard immigrants externally. Our mandate is much more operational, making sure we bring them in and we settle them afterwards. So the research that was done does highlight specific concerns, gaps in terms of the immigration population. We brought it back to our policy folks. In theory, some of it they use as insight. I think there's a good example in the previous deck in ensuring we can have on the ground what's the messages that we can give to this immigration population when it comes time to vaccines. How can we get to them? So that did enable that, but there's nothing quite as concrete as, for instance, public health could have has done in this sphere. And so I might be speaking on behalf of the bigger Canada family when I say that the importance and the relevance of the data being linked together is not just for our department, but also for other departments that supplement or complement our mandates, such as public health and Health Canada. So we were able to use the information from the linking on COVID specifically to bring the data back to the PCO and the Prime Minister's office. It helped in sharing how things were going at various levels and probably helped in the PM making some decisions, but it's not completely related to the work IRCC does. On the last slide, I think that's where you will most be interested, is where are we going? What direction do we have in the future? I saw there was a question in the chat on temporary residence. We've just recently linked the data, so I mean, till this August of last year. So it's only recent, but going forward, it brings in new possibility. We are also planning for our next immigration level, and I'm sure you've heard there's been different opinions on those in the media. It's quite aggressive, and when we talk about data, we have to be conscious of what is the health, the settlement abilities in different areas at the provincial level to welcome all these immigrants, and how does the federal government make decisions on these levels and use the data that's available to inform the decisions, inform which categories of immigrants should come or can come, and where our efforts should be made in terms of revisiting our policies and our programs. The focus in the immigration levels will be about newcomer health outcomes. We know already that a number of provinces are facing challenges. Ontario is one of them as well. And so the question could be, are we burdening more the health system by bringing in different types of immigrants who have different types of backgrounds? What can the data that we have today that's linked with today's population give us insight for the future? The healthcare use and access for the different permit categories, what's the impact of health, what's the health situation when we talk about international students, super visa holders, and so forth. And obviously of interest as well is the refugee resettlement. So how can we help in this sphere? So I made it short and sweet. I'm sure the organizers are quite happy about that. But I do welcome any questions you have. You have my contact info. My team can answer you. So thank you.
Thanks so much, Sarah, and to Seema and Sujitha as well for your fantastic presentations. I know we're quite short on time today, so I think if you have any additional questions, we can put contact information in the chat, and please feel free to email with those. And I know another session is starting shortly, but thank you so much. Really appreciate it. Great opportunity to see kind of the full cycle where, you know, we have the research really informing some decision making during a pandemic, and hopefully that can continue as well.
Well, thanks, Sujitha, and thanks to all the panel participants for another terrific panel. Really thought-provoking and a great example of an important whole area to consider as part of a health equity agenda. So with that, we'll move into the next session, and I will see you over there very shortly.